Right now, in both of your kidneys combined, there are approximately 1 million tiny filtration units working continuously, filtering your entire blood volume roughly every 30 minutes, removing waste, regulating your blood pressure, balancing the concentration of every electrolyte in your body, and producing hormones that determine how many red blood cells you make and how strong your bones remain over time. They do all of this without any signal from you, without rest, and without complaint, including when they are losing the ability to do it. That last point is the one that matters most. Kidney disease is clinically silent for the vast majority of its progression. There is no pain. There is no specific fatigue that announces itself as renal in origin. No symptom that sends a person to their GP and results in the discovery that their kidney function has been declining quietly for years. By the time symptoms appear, swelling in the legs, persistent fatigue, changes in urination, shortness of breath, the kidneys have typically lost more than half their functional capacity, and in many cases, irreversibly. There is a number on almost every standard blood test result that reflects this functional capacity in real time. It appears as a single figure alongside creatinine on the routine panel that millions of people receive every year. It is routinely underexplained, routinely misunderstood, and routinely ignored until it crosses a threshold that by that point represents damage that has been accumulating for a decade or more. That number is eGFR, estimated glomerular filtration rate. And by the end of this video, you will understand what it means, why it matters far more than the way it is currently communicated suggests, and critically, what the early trajectory of that number is telling you about your cardiovascular and metabolic health years before any kidney diagnosis is made. Your kidneys are failing silently in millions of people who have had the number that measures their function printed on their blood test results for years. The number exists, the explanation has not been provided. Hi, I'm Dr. Alex. I'm an emergency medicine doctor, and after nearly 10 years working in the AANDE, I've seen kidney disease at its most acute and its most irreversible. The dialysis-dependent patients presenting with fluid overload, the acute kidney injuries triggered by dehydration or medication in people whose baseline function was already compromised, the cardiovascular events in patients whose declining eGFR was a years-long warning that was never acted upon. My goal now is to give people the understanding of that number, what it represents, what its trajectory means, and what determines it, that the standard blood test communication has consistently failed to provide. If you're watching this video, your kidney health is something you care about, or something a recent blood test result has made you start thinking about more carefully. I want to make you a promise. I promise to keep creating the most detailed, evidence-based videos I can grounded in real clinical experience and the latest research to help you understand your body and protect your long-term health. All I ask in return is that you give this channel a chance and hit the subscribe button. If you reach the end of this video and haven't genuinely learned something new, feel free to unsubscribe, no hard feelings at all. But if you give me your time and attention, I will give you everything I have learned from nearly a decade in emergency medicine. Please hit subscribe to help this channel reach more people like you. And let's get into it. To understand why eGFR is the kidney function number most people ignore and why that neglect is consequential, you first need to understand what it is actually measuring and why the way it is currently communicated creates a false sense of security for millions of people. eGFR stands for estimated glomerular filtration rate. The glomerulus is the individual filtration unit within each nephron, the functional building block of the kidney. Each kidney contains approximately 500,000 nephrons, and each nephron contains a glomerulus, a tiny knot of capillaries across which blood is filtered under pressure, with waste products and fluid passing through into the tubule while blood cells and proteins remain in circulation. The glomerular filtration rate is a measure of how many milliliters of blood are being filtered by the glomeruli per minute. A healthy young adult filters approximately 90 to 120 milliliters per minute. eGFR estimates this rate from a simple blood test measuring creatinine, a waste product of muscle metabolism, alongside age, sex, and in some calculators, ethnicity. The critical problem with how eGFR is communicated is the reference range. Standard laboratory reports flag eGFR as normal if it falls above 60 milliliters per minute per 1.73 square meters of body surface area. Below 60 is defined as chronic kidney disease stage 3 or above. Above 60, most patients are told their kidneys are fine. And this is where the clinical failure occurs, because an eGFR of 62 and an eGFR of 105 are both reported as normal, but they represent dramatically different functional states, dramatically different trajectories if current conditions continue, and dramatically different cardiovascular risk profiles. The binary of above 60 versus below 60 obscures a continuous gradient of kidney health that carries real and measurable consequences long before the diagnostic threshold is crossed. Normal does not mean optimal. An eGFR of 65 and an eGFR of 110 are both reported the same way on a standard blood test. They do not mean the same thing for your kidneys, your cardiovascular system, or your longevity. Here is where it gets critically important and where the biology of kidney disease diverges from almost every other organ system in a way that makes early detection uniquely challenging. The kidneys have a remarkable and ultimately dangerous capacity for compensation. When nephrons are damaged by high blood pressure, by elevated blood glucose, by inflammatory injury, by medication toxicity, or by the simple mechanical stress of obesity-driven hyperfiltration, the remaining healthy nephrons compensate by increasing their individual filtration rate. The total eGFR stays relatively stable even as the underlying nephron population is declining. This compensatory hyperfiltration is protective in the short term, but accelerates damage to the remaining nephrons in the medium and long term because each surviving nephron is being asked to do more than it was designed to sustain. The result is a kidney that maintains a reassuring eGFR reading while quietly losing the reserve that would allow it to withstand an acute insult, a dehydration episode, a contrast dye procedure, a course of non-steroidal anti-inflammatory medication without tipping into acute kidney injury. The trajectory of eGFR over time is more informative than any single reading, and this is one of the most clinically significant points in this entire video. A person with an eGFR of 80 that has been stable for 10 years is in an entirely different position from a person with an eGFR of 80 that has fallen from 105 over the same period. The first person has good kidney function. The second person has a kidney disease process in progress that a single cross-sectional reading completely fails to reveal. Most people have never been told to track their eGFR over time. Most people have never been shown that a downward trend, even one that remains within the normal range, is a clinically meaningful signal that warrants investigation and intervention. A single eGFR reading tells you where the kidneys are today. The trajectory over years tells you where they are going, and the trajectory is the number that actually matters. Now, what makes the eGFR number far more significant than a simple measure of kidney function, and what makes its neglect particularly consequential, is the relationship between declining kidney function and cardiovascular disease risk. This relationship is one of the most robust and well-replicated findings in nephrology and cardiology, and it is almost entirely absent from the way eGFR is communicated in routine clinical practice. Research published in the New England Journal of Medicine, drawing on data from over 1 million adults, demonstrated a continuous, graded relationship between declining eGFR and increasing risk of all-cause mortality, cardiovascular mortality, and hospitalization, with the risk increasing measurably at eGFR values, well above the standard 60 milliliter threshold. An eGFR of 75 carried measurably higher cardiovascular mortality risk than an eGFR of 95 in the same study population, after adjusting for all conventional cardiovascular risk factors. The kidney decline was not simply a consequence of cardiovascular disease. The declining eGFR was independently predicting cardiovascular events, because the two processes share a common set of upstream drivers, and because the kidney has a direct role in regulating blood, pressure, fluid balance, and the inflammatory environment that determines arterial health. The mechanism connecting impaired kidney function to cardiovascular risk operates through multiple pathways simultaneously. Declining eGFR reduces the kidney's ability to excrete phosphate, leading to elevated parathyroid hormone and vascular calcification. It impairs the production of erythropoietin, causing anemia that increases cardiac work. It reduces the activation of vitamin D, impairing endothelial function. It drives sympathetic nervous system activation that raises blood pressure. And it allows the accumulation of uremic toxins, waste products that would normally be cleared in the urine that directly damage endothelial cells and promote atherosclerosis. Each of these pathways is active long before the eGFR falls below the diagnostic threshold for chronic kidney disease. A declining eGFR is not just a kidney warning. It is a cardiovascular warning, a bone health warning, a blood pressure warning, and a longevity warning, all expressed in a single number that most people have never been told how to read. Just very quickly, if you're finding this useful so far, please consider hitting subscribe. It genuinely helps these videos reach more people who need this information. Right, let's continue. So let me name this directly because I want it to land in practical terms. The mistake, the one being made in millions of routine clinical consultations every year, is treating eGFR as a binary pass or fail threshold, rather than as a continuous biological signal that carries meaningful information across its entire range. It is accepting a single reading of 68, or 72, or 78 as unremarkable because it clears the threshold of 60 without asking whether it has fallen from 95 over the preceding 5 years, without understanding what that trajectory implies about the kidney's reserve capacity and the cardiovascular risk already accumulating, and without connecting that number to the blood pressure that has been gradually rising, the blood glucose that has been trending upward, and the visceral fat that has been accumulating. All of which are both driving the eGFR decline and being driven by it simultaneously. The kidney function number most people ignore is not below 60. It is the reading of 72 that was 91 4 years ago, unremarkable on any single result, and a decade-long warning written in plain sight across the blood test history that nobody has been asked to read as a sequence. This shows up in a few distinct clinical patterns. The most common is the patient in their late 50s or 60s who has had annual blood tests for a decade, and whose eGFR has drifted from the low 90s to the low 70s over that period. At no point has any individual result fallen below 60. At no point has any single result been flagged as abnormal. And at no point has anyone sat down with that patient and said, your kidney filtration rate has declined by more than 20% over 10 years, which tells us something important about the blood pressure, the metabolic health, and the vascular condition of the filtration units in both kidneys. The trend has been there, the conversation has not. The less obvious version is the patient who is managing type 2 diabetes or hypertension, and whose eGFR is checked annually as part of their monitoring protocol, but who has never been told that their eGFR is the single most important number in that annual panel for predicting their long-term renal and cardiovascular trajectory. The cholesterol gets discussed in detail. The HbA1c gets a full conversation. The eGFR is noted, compared to the threshold, found to be above it, and moved past. Then there is the category that I find most instructive, the person who takes their blood test results home and looks at the numbers themselves, as increasing numbers of people do, particularly in an era of online patient portals, and who notices that their eGFR has been falling slowly but consistently over several years, brings it to a clinical appointment, and is told not to worry because the number is still in the normal range. The concern was appropriate, the response was insufficient, the trajectory was the signal, and the signal was not read. A declining eGFR does not go unaddressed because people are indifferent to their health. It goes unaddressed because the communication framework around routine blood tests was not designed to convey trajectory. It was designed to convey whether a single value on a single day falls within a reference range. That framework is adequate for detecting acute kidney injury and advanced chronic kidney disease. It is inadequate for the far more common and far more actionable situation of early progressive kidney function decline that has not yet crossed the threshold but is tracking toward it in a person who can meaningfully change that trajectory with the right information and the right interventions. The system communicated incompletely. The person followed what they were told. That gap is where early kidney disease quietly advances. So what is the practical response? I want to frame this carefully. I am not suggesting that everyone needs to become preoccupied with their eGFR, or that a reading of 75 in the absence of a declining trend requires urgent intervention. What I am saying is that eGFR deserves to be understood as a continuous health signal, tracked over time and connected to the modifiable upstream drivers that determine whether it remains stable or continues to fall. The interventions that protect kidney function are not exotic or specialized. They are the same lifestyle and metabolic interventions that protect cardiovascular health, metabolic health, and longevity, more broadly, which reflects the fact that they share the same upstream causes. The first and most immediately actionable step requires no new tests and no new appointments. It requires going back through your existing blood test results available through online patient portals in most healthcare systems and plotting your eGFR readings over the years. They are available. If you have been having annual blood tests for 5 or more years, you have a trajectory. A stable eGFR, even one in the low to mid-70s, is a fundamentally different clinical picture from a falling eGFR that has declined 10 to 15 points over the same period. The trajectory is the diagnostic, the single reading is not. If your eGFR has been falling consistently, even while remaining above 60, that is a conversation worth initiating with your GP. Ask specifically about the trend, not the current value. Ask whether the rate of decline, if extrapolated, projects toward the threshold for chronic kidney disease within a clinically relevant time frame. Ask whether the upstream drivers, blood pressure, blood glucose, proteinuria, medication exposure, have been assessed and optimized in the context of that trend. These are questions your GP can answer. They are questions that the standard blood test communication has not been prompting people to ask. The single most important modifiable driver of eGFR decline is blood pressure. The glomeruli, the filtration units, are directly exposed to the arterial pressure driving blood through the kidney. Chronically elevated pressure damages the delicate capillary walls of the glomeruli through mechanical stress, accelerates glomeruli sclerosis, the scarring of filtration units, and reduces the nephron population over time. The relationship between blood pressure and eGFR decline is dose-dependent. The higher the sustained blood pressure, the faster the filtration rate falls, and it operates at blood pressure levels that are well within the conventionally acceptable range. Research published in the Journal of the American Medical Association demonstrated that intensive blood pressure control, targeting a systolic below 120 millimeters of mercury rather than the conventional target of below 140, produced significantly slower eGFR decline and lower rates of cardiovascular events in people with elevated cardiovascular risk. The practical implication is that a blood pressure of 135 systolic, technically within the normal range, is not necessarily optimal for kidney preservation in a person with a declining eGFR trend. The target that protects the kidneys is lower than the target that avoids a hypertension diagnosis. If your eGFR has been falling and your blood pressure sits consistently above 125 systolic, that combination deserves specific attention, both through lifestyle intervention and through a clinical conversation about whether the blood pressure target is appropriate for your renal trajectory. Blood pressure is the primary hydraulic force acting on kidney filtration units every second. Getting it into the genuinely optimal range, not merely the normal range, is the single most evidence-based thing a person can do to slow eGFR decline. The second major modifiable driver of eGFR decline is the metabolic dimension, specifically elevated blood glucose and the insulin resistance that precedes it. Diabetic nephropathy is the leading cause of end-stage kidney disease in the developed world, and its earliest measurable sign, increased protein in the urine, called microalbuminuria, typically appears years before any eGFR decline is detectable. But insulin resistance drives kidney damage through mechanisms that operate independently of overt diabetes. Elevated insulin promotes glomerular hypertension through its effects on the renin-angiotensin-aldosterone system, Advanced glycation end products from chronically elevated glucose directly damage the glomerular basement membrane, and the systemic inflammatory environment of insulin resistance accelerates the glomerular sclerosis that progressively reduces nephron number. The dietary and exercise interventions discussed in previous videos, reducing refined carbohydrate and fructose intake to lower insulin exposure, progressive resistance training to improve insulin sensitivity, and visceral fat reduction are therefore directly relevant to kidney protection, not simply cardiovascular and metabolic health. Research published in The Lancet Diabetes and Endocrinology has demonstrated that in people with early diabetic kidney disease, intensive metabolic control, including blood glucose optimization through dietary change and GLP-1 receptor agonist therapy, significantly slows the rate of eGFR decline. The kidney is not a separate system from the metabolism. It is one of its most sensitive downstream indicators. The fourth category of intervention is about what to avoid, because many people with declining eGFR are unknowingly exposing their kidneys to additional damage through common medications, practices that are nephrotoxic, particularly in the context of already reduced reserve capacity. Non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, and similar medications reduce blood flow to the kidney through their prostaglandin inhibiting mechanism. In people with a full complement of healthy nephrons, this is temporary and well tolerated. In people with a declining eGFR, where compensating nephrons are already working near capacity, NSAIDs can precipitate acute kidney injury on a chronic kidney disease background. This combination, acute on chronic kidney injury, is one of the most common precipitants of hospital admission in older adults with previously unrecognized renal impairment. Regular use of over-the-counter NSAIDs for pain management in someone with an eGFR in the 60s is a risk that most people in that situation have never been warned about. Adequate hydration during illness, avoidance of contrast dye procedures without prior nephrology consultation, when eGFR is declining, and awareness of which prescribed medications carry dose adjustment requirements at reduced kidney function, are all practical protective measures that require nothing beyond information to implement. I want to be clear that if you are already on medication for blood pressure, diabetes or kidney disease, ACE inhibitors, ARBs, SGLT2 inhibitors, or any other renal protective treatment, nothing in this video is a reason to adjust or stop without speaking to your doctor or nephrologist first. These medications are among the most evidence-based renal protective interventions we have, and they work most effectively when the lifestyle foundation described here is in place alongside them. Let me bring this back to what I see clinically, because the significance of eGFR trajectory becomes considerably more concrete when it is grounded in actual patient patterns. In emergency medicine, acute kidney injury is one of the most common serious complications we manage, and it is overwhelmingly more severe, more prolonged, and more likely to result in permanent additional kidney function loss when it occurs in a person whose baseline eGFR is already compromised. A dehydration episode in someone with an eGFR of 95 is a temporary inconvenience that resolves within days. The same dehydration episode in someone with an eGFR of 60, which has been trending downward for a decade, which the person was told was normal and which nobody has connected to the blood pressure that has been running at 138 systolic for years, is a potential trigger for an acute kidney injury that drops them into stage 4 chronic kidney disease, from which they do not fully recover. The reserve was not there. It had been quietly eroding for a decade, and no single blood test had ever flagged it as abnormal. I have also seen the other side, patients who, after understanding the trajectory of their eGFR and the upstream drivers, bring their blood pressure into the genuinely optimal range, reduce their metabolic insulin load, stop their regular ibuprofen use, and return 6 to 12 months later with an eGFR that has stabilized or marginally improved. Kidney function, once lost, does not regenerate, but the rate of loss is modifiable significantly in most people through the interventions described here. Stopping the decline before it reaches irreversible territory is the prize, and it requires acting on the trajectory well before the threshold is crossed. Chronic kidney disease affects approximately 10% of the global adult population, roughly 850 million people. It is the only major chronic disease whose prevalence is increasing while the others are beginning to stabilize or decline. And the overwhelming majority of people in the early stages of CKD, eGFR between 60 and 90 with a declining trend, have no idea they are in those stages, because their individual blood test results have never crossed a threshold that triggered a clinical conversation. What makes this particularly significant is the relationship between eGFR and the full spectrum of chronic disease outcomes discussed across this series of videos. The same insulin resistance that drives visceral fat accumulation, that powers the afternoon energy crash, that elevates resting heart rate and drives cardiovascular risk, is also the primary metabolic driver of glomerular hypertension and progressive kidney function loss. The same chronic low-grade inflammation that produces neuroinflammation and brain fog is directly damaging to glomerular capillary walls. The same blood pressure elevation that accelerates cardiovascular aging is acting on kidney filtration units with each heartbeat. These are not parallel conditions running independently in the same person. They are expressions of the same upstream metabolic and vascular dysfunction, each revealing itself in a different organ system. The eGFR is, in this sense, one of the most integrative health metrics available in routine blood testing. It reflects the cumulative vascular and metabolic burden that the kidneys have been absorbing over years, a silent record of blood pressure, blood glucose, inflammatory injury, and perfusion pressure, written into the filtration capacity of a system that neither complains nor warns until the damage is already substantial. Reading it as a trajectory rather than a threshold is the difference between early intervention and late discovery. So let me bring this full circle. The kidney function number most people ignore is not the one below the threshold, the one that triggers a diagnosis and a clinical response. It is the one that has been falling quietly within the normal range for years, printed on annual blood test results, noted and filed without context, while the underlying process it reflects has continued uninterrupted. eGFR is not a pass or fail score. It is a continuous biological signal of kidney filtration capacity, cardiovascular vascular health, metabolic burden, and long-term organ resilience, and its trajectory over time is one of the most informative readouts available in routine clinical testing. Tracking it as a sequence rather than a snapshot, connecting it to the upstream drivers that determine its direction, and acting on a declining trend while the reserve capacity still exists to change it. These are the three things that turn a number most people ignore into a number that changes clinical outcomes. Your eGFR has been on every blood test you have had for years. Go back and look at what it has been doing. The trend is the message, and now you know how to read it. If this video gave you something genuinely useful today, a framework for understanding a number that has been in front of you without explanation, please subscribe to the channel and help us reach more people like you who deserve this information.